Hey, hi everyone. My name is Alexis Marbach from APT Associates, working on the Dissemination of Evidence-Informed Interventions project. And I'm so excited to welcome you today to our Clinical Coordinator webinar, Clinical Coordinators, Core Medication-Assisted Treatment Team Members. We have a pretty packed webinar, so we're going to get started on time today. So thank you so much for joining. We have a great team of presenters compiled for you today. We have presenters from each of our demonstration sites who we'll introduce in just a moment. And I'm also joined by Serena Rajabian, the PI at Boston University, my colleague Hannah Bryant from AIDS United, and our project officer, Dr. Corliss Heath from HRSA. So our objectives for our webinar today are to describe the role of the clinical coordinator as part of the workforce to enhance MAT and primary care. We're going to talk a little bit about the findings from our HRSA SPINS project, integrating buprenorphine treatment into HIV primary care, and share lessons learned from our time on that initiative. Pass the mic to our project officer, Dr. Corliss Heath, to introduce our initiative and give us a little background on how we arrived at this webinar.
Good afternoon, everyone. The dissemination of evidence-informed interventions to improve health outcomes along the health care continuum, which we fondly call the DAE initiative, was funded through the SPINS project of national significance, the SPINS program, and this 5-year initiative used an implementation science approach to adapt 4 interventions that were previously implemented through SPINS initiatives. AIDS United was funded as the Implementation and Technical Assistance Center and to provide technical assistance to assist 12 demonstration sites. And then Boston University served as the Demonstration and Evaluation Center to those demonstration sites. Next slide, please. And so here we have the 4 interventions that were previously funded through SPINS. The 4 interventions were enhancing linkages for those newly released from jails, more commonly known as the SPINS Jail Initiative. Now it is the in the DAE initiative, it was the Translational Care Coordination Intervention. We have the Targeted HIV Outreach and Intervention Model Development and Evaluation for Underserved HIV-Positive Populations Not in Care, which was commonly known as the SPINS Outreach Initiative. And in this initiative, it was the it was the Enhanced Patient Navigation for HIV positive for HIV positive women of color, which is the one at the bottom. An evaluation of innovative methods for integrative buprenorphine opiate abuse treatment in HIV primary care, which was known as the Buprenorphine Initiative, is the integrated buprenorphine treatment for opiate use disorder in HIV primary care for the DAE initiative. And then finally, what was previously the Secretary's Minority AIDS Initiative, or the SMAIF Retention and Reengagement Initiative. In the DAE initiative is the peer linkage and reengagement of HIV positive women of color.
Great, thank you, Corliss. I also want to remind folks, and I should have done this at the top of the webinar, but we'll be answering questions in the text chat as we go through the webinar, and then we'll also save some time at the end for questions. So please feel free to ask questions of the presenters, of the ITAC, so that's the AIDS United team, or the evaluation team, which is the Boston University and APT team. We're happy to answer questions as we go. So this intervention, the integration of buprenorphine treatment, has a few key components. I'm going to turn it over to my colleague Hannah at AIDS United to walk us through the background of this intervention.
Thanks so much, Alexis, and good afternoon, everyone. So as many of you know, buprenorphine is an FDA-approved medication for opioid use disorder, which can be delivered in the primary care office setting. Programs offering buprenorphine treatment can take many different structures, but I will briefly highlight a few unique components of the buprenorphine intervention implemented through the DAE initiative that Dr. Heath talked about. The DAE buprenorphine intervention was intentionally implemented in HIV primary care settings that did not have on-site buprenorphine services available prior to the implementation of the DAE initiative. This allowed us to look at the client-level impact of treatment as well as the systems-level change of incorporating buprenorphine into clinic standard of care. Programs were also embedded into the HIV primary care setting so that providers could treat opioid use disorder alongside other chronic medical conditions and build on the established relationship between a client and their primary care team. Lastly, clinics funded through the DAE initiative were also intentional about incorporating harm reduction principles into their buprenorphine program. Utilizing this model, 97 clients living with HIV and an opioid use disorder were served through 3 Ryan White clinics participating in the DAE initiative between November 1st, 2016 and April 30th, 2019. Next slide.
Great, thank you, Hannah. So as Hannah mentioned, we had 3 sites that were funded as demonstration sites for this project. We had the University of Kentucky Bluegrass Care Clinic, Metro Health, and Centro Ararat, which we'll discuss on the next slide. So here we just wanted to explain a little bit about the background of each site so you could get a better sense of where our clinical coordinators are coming from, and then talk a little bit about their HRSA SPN's work and see, so we can get a better sense of what it takes to get this work off the ground. So the University of Kentucky Bluegrass Care Clinic, which we call the UK Clinic or BCC interchangeably, they are a Ryan White funded HIV primary care clinic within the UK healthcare system, and they're located in Lexington, Kentucky. And their clinic serves 63 out of Kentucky's 120 counties, so they have a pretty large service territory. Prior to the intervention, the Bluegrass Care Clinic referred patients to community partners for MAT. So this was the first time that they were able to bring buprenorphine services in-house. Ryan White Part B funds provided limited financial assistance to support the cost of MAT. So our next demonstration site is Metro Health. Metro Health is a public health hospital system in Cleveland. It's comprised of the main hospital complex and clinics, 2 mini emergency departments, and a skilled nursing facility, along with an acute rehab facility and 30 community health centers. Prior to this intervention, the Metro Health System had 1 active Suboxone provider, so this was really a big scale up for them. All right, so our next implementation site was Centro Ararat, which is in Juana Diaz, Puerto Rico. They're a nonprofit institution that provided access to community-based primary care, mental health care, preventative and social services. And prior to this intervention, they had no existing MAT program. So you can see that a lot of our clinical coordinators were really starting from scratch here, so we hope that there are lessons learned for folks that are on the call who are just looking into a program and looking to see how to get one off the ground. We're also joined today by our colleague from the Multnomah County Health Department. So Multnomah County Health Department was not a site in this intervention, but they were the technical assistance provider for this intervention, as they had been a demonstration in the SPN's initiative that preceded this initiative, the Beehives initiative. So this demonstration site, this training and technical assistance provider, Kristen, who we'll introduce in just a moment, can give you a bigger context of what it takes to get both off the ground and then how to sustain an initiative. So they are a primary and specialty HIV clinic within Multnomah County in Oregon. They've been providing HIV primary care since 1990, and it's the only Ryan White funded medical provider in Oregon. They participated in the SPN's initiative in 2005, so that's the Beehives initiative that I referenced earlier, and have been providing MAT since then. So these are our wonderful clinical coordinators who we're so excited to introduce you to. So we'll do just a brief introduction here so that you can get a sense of who you'll be hearing from, and then we'll launch into more of their individual stories in just a moment. So first I want to introduce Diana Ball. Diana is from the University of Kentucky Bluegrass Care Clinic, and we'll be going from left to right so you can see who you're talking to. Diana is an addiction program coordinator. She has an experience and education in psychology. She's a licensed clinical social worker, currently working on her PhD. She has 1 year in addiction and mental health counseling in rural Kentucky, 4 years in medical case management at the Bluegrass Care Clinic, and works largely with people with substance use disorders. So welcome, Diana. We're happy to have you. And then Jason. Jason is a clinical coordinator and medical case manager and supervisor in the HIV clinic at the Metro Health System in Cleveland. He is a licensed independent social worker in Ohio and has worked in the HIV clinic for 15 years. Hi, Jason. It's nice to have you here.
Hi, everyone. Good afternoon.
Hi. And then I'll turn it over to Hannah to introduce our clinical coordinator teams from Centro and from Multnomah County.
Thanks, Alexis. So we're also thrilled to have with us today Ana Gonzalez, who's a nurse at Centro Ararat in Juana Diaz, Puerto Rico. She has 30 years of experience working with the clinical care of people living with HIV and served as a clinical coordinator and HIV nurse on this project. Welcome, Ana. We're also joined by Delhia Cruz Torres from Centro Ararat in Juana Diaz, Puerto Rico. She is an addictions counselor with a master's degree in mental health counseling. She's also certified as an addiction therapist and master addiction counselor. She has 11 years of experience coordinating buprenorphine programs in the mental health setting and providing addiction and mental health counseling. Welcome, Delhia and Ana.
Hi, everyone.
Hi, everyone.
And our last clinical coordinator joining this call is Kristen Myers. She is a medical case manager at the Multnomah County Health Department, and like Alexis mentioned, was a technical assistance provider for this project. She started as an addictions counselor in 2005 for the original SPN's buprenorphine beehives project that Alexis referenced. Welcome, Kristen.
Hi, everyone. Thank you, Hannah.
All right, thank you, guys. So great to see all of you here. But, you know, we should really take a step back and talk about the role of the clinical coordinator. So why are we all here? We want to know more about who this person is and the role that they serve in the clinic and how they can benefit the intervention. So the clinical coordinator, we had a pretty standard definition that we used across all of our demonstration sites that we received from the Beehives Initiative, so you could say across all 4 sites that we're talking to today. But there were really 2 key components, and then each site layered on their own expertise, their own specialty services that they needed to meet the needs of their client population. So the standard things that were across all the clinical coordinators were that they were working to support and stabilize patients in buprenorphine care. And they were working in collaboration with the primary prescribers, treatment team, and the patient. So as you can see, that's a pretty broad definition. So let's drill down a little bit to how this played out at each site. So Diana, we'll start with you. Can you tell us a little bit about how the role of the clinical coordinator took shape at the University of Kentucky?
Yeah, absolutely. So at the BCC, we created the clinical coordinator role as a hybrid between case management and counseling. So I met with patients at each visit with the prescriber to conduct brief counseling and to assess for potential barriers to care. As we previously noted, our case or our catchment area is so very large. And so a lot of those barriers to care we'll talk about later in the program. But I really worked to identify those and then, and work to resolve those. I also provided supervised dosing for patients who struggled to take medicine appropriately. And I think one thing that we did that was a little different than other programs in the intervention was the prescriber and I often would kind of tag team patients in clinic. So depending on what the patient needed, sometimes the three of us would meet. It would be the prescriber, myself, and the patient in the room together, and we would all sit down and talk about how the patient is doing and what we as a team can do to help them. Sometimes the doctor would go in first, and sometimes I would go in first, depending on what we thought would be the best way to meet the patient and their needs.
Great, thanks, Diana. So it really sounds like you had a collaborative approach that you used with your primary prescriber and the whole treatment team. So I'm looking forward to hearing more about that when we dive into our patient experience story in just a moment.
Absolutely.
Jason, thanks. And Jason from Metro, can you share a little bit about the role of the clinical coordinator at your site?
Yeah, sure. Some of the things are similar to what Diana said. Of the 10 HIV providers at Metro Health, 2 providers became Suboxone prescribers, and I worked with those 2 providers specifically on helping manage the patients. I would kind of be the go-to person that the patients could come to. I would be their first contact after they checked in at the clinic. I would bring them back to a room, do urine screens, talk to them about how things are going, things that we'll get into later. So the 3 of us, as far as myself and then the 2 prescribers, were the main players, and I would work with both of those prescribers as far as making sure that the services were delivered and that patients were getting the care under this intervention that they needed.
Great, thank you. Anna and Delgia, can you tell us a little bit about the role of the clinical coordinator at Centro?
Yes. My main role is to offer support to the clinical coordinator, Anna, and by my profession, I offer addiction counseling to the participants. At the beginning of the project, at the implementation phase, I was in charge of the development of protocols, service manuals, and clinical forms according to the law and the health regulations established by the health agencies in Puerto Rico. As Hannah mentioned, it was the first time that Centro Ararat offered medication-assisted treatment with Buprenorphine. So within my duties, I offer trainings to the clinical and non-clinical staff. I also identify and develop educational material for participants. As an important part of the sustainability of the project, I identify community agencies and develop collaborative agreement to make and receive referrals. That's
great.
the summary.
Delgia, you just reminded me that another big piece of the clinical coordinator role is to understand the DEA and the federal regulations around providing buprenorphine and providing training to other clinical team members that want to work with your team but may not know the ins and outs of MAT or substance use treatment. So that's another piece that the clinical coordinator can take on. Kristen, can you tell us a little bit more about your role at Multnomah?
Sure, thank you. So I started back in 2005 with the SPINS initiative, as you mentioned, and in that time we didn't have really any kind of structure or idea of how this program would look, but we quickly realized that the role of the clinical coordinator, or kind of known as the glue person, really helped make the program more successful in regards to making sure that clients were getting connected to care, we were coordinating services, and working with community providers. And so we've had, the past 14 years to kind of move from that time frame and developed a different kind of protocol and plan. We've went from 2 providers that were prescribing to now 4 providers that were prescribing. And we've kind of come in and out of different phases of how we provide services. And lately we've moved to more of a kind of low barrier access clinic services, and so we've also really focused on relying on our medical home team model, and so we utilize several people within the clinic, and I think we'll talk about that in a couple slides or the next slide, about really focusing on all team members, from our nurses to our navigators, and that's how we are continuing our MAT services now.
Oh, great. So you also reminded me about the term glue person. So those who are getting into MAT treatment who may be learning a little bit more and trying to figure out what team members to bring in. You may also hear a lot about a glue person and the value of a glue person, and that is the same as the clinical coordinator. So they're the person that really holds the intervention together in many ways because they serve as a connecting point between the primary prescriber, the treatment teams, the patient. So yeah, we affectionately refer to these colleagues as glue people as well. So Hannah, let me pass it over to you to talk more about working as part of larger treatment teams.
Definitely. So I think you all have already heard reference that another intentional component of the buprenorphine intervention funded through the DAE initiative is the incorporation of a multidisciplinary treatment team. While we're focusing on the clinical coordinators during today's webinar, we did want to quickly reference that these clinical coordinators are part of a wider multidisciplinary treatment team, and you'll see the different roles that are part of those treatment teams on this slide. But Kristen, I'm wondering if I could start with you so we go the other way, if you could reflect briefly on who's part of the treatment team at your site.
Yeah, sure. So as I mentioned earlier, we just went from 2 prescribing providers to 4 prescribing providers now. We have 5 medical case managers, and so our medical case managers will provide direct resource referral connections for their caseload that they're serving. And that is my primary role that I serve here in the county, is actually as a case manager with a caseload. We have behavioral health specialists on site to provide counseling and medication assistance. We have coordinated with another agency where we have peer mentors on site where we can refer clients to work with a peer one-on-one. We will actually start, we got a new grant, and we'll be hiring a specific person who will be providing behavioral health addiction counseling services. We also work really closely with our community health navigators. Those are staff that can actually go out into the community with our clients. And that's a program that we added about 2 years ago. And even in this role, that's been kind of a key engagement point for us in regards to either re-engaging clients who've fallen out of care with our MAT program or clients that we're trying to get into the MAT program. Our navigators have really helped us kind of doing more of that street-based outreach. And then we also coordinate with our addiction benefit coordinators. They kind of act like treatment brokers, and they can help get clients fast-tracked into treatment facilities if that's something they needed.
Thank you, Kristen. It's really interesting to hear about all of the different team members and roles that are part of your treatment team at the Multnomah County Health Department. Centro, our team, Anna and Delhia, I know that you all have a bit of a different structure or different key roles that are part of your treatment team, so hoping that you all can talk to us about that structure as well.
Yes, we have 2 prescribers, but we have others prescribed at the other clinic in San Juan and other areas in Puerto Rico with the buprenorphine waiver in case we need a backup. And each professional, the psychologist, the nutritionist, the case manager, and the other members perform an assessment in their areas, which facilitates the identification of participant needs, and we as a team could attend those needs. So having as part of the team a case manager and others help us direct all efforts in meeting the goals of the patient treatment plan. We also have an outreach team that we are going to talk about this team in the future. Some slide ahead. But we have this team, and we have a team leader, we have a nurse, and we have a peer who access potential participants in a high-risk area.
Great. Thank you, Delhia.
You're welcome.
So I think you all can see from the slide and what Kristen and Delhia highlighted, there's multiple different structures that a buprenorphine treatment team can take, but what's really key is having that multidisciplinary team with those multiple staff members who can fill different but unique roles for the client. In the interest of time, I'm going to have us move on to the next slide and say that Diana and Jason, if there's anything about your all's treatment teams that you'd like to highlight, I'd ask you to highlight those on the following slide.
Great, thanks. Thanks, Hannah, and thanks, clinical coordinator team. So one of the things that we heard loud and clear when we started doing site visits about 3 years ago was that when you take your training to become a waivered physician, and folks on the call who are participants might share this opinion, so please share in the text chat if so, was that the training makes it seem like buprenorphine care is really linear, right? Like you get a client enrolled, they get induced in buprenorphine care, and then all of a sudden everything is wrapped up and done, and they go on living their life. And we know from experience that that is not true. And although the clinical coordinators work with large treatment teams, as we just talked about in the previous slide, they do intersect the treatment path at pretty critical intersections. So we asked the treatment teams to come up with what we would call the patient journey. So on this graphic, you can see the blue line is that kind of linear pathway. You know, if someone was to just be identified, be induced, have their monitoring appointments, and stabilize on buprenorphine treatment. And our red dotted lines are all of the points where clients have stumbled or they have been challenged with staying on track with their buprenorphine treatment. So the clinical coordinators and Hannah talked about ways to talk about this patient journey, and what we've decided is that we would come up with kind of the, you know, test case patient, like the patient that has all of the different barriers. So the clinical coordinators are going to walk us through what they have done as clinical coordinators across all demonstration sites, and then talk a little bit about their own individual experiences, so how they change some of their steps based on their own communities and patient needs. So I'll hand it over to Anna and Delgia to kick us off to talk about how they identified patients in the clinic.
Thank you. As I said, in Centro Rarat, we have an outreach team who streamlined the process of recruiting new participants. They also map the areas to impact the hard-to-reach population and provide patient follow-up, improving the adherence to treatment. We also receive referrals from community agencies and other participants. The screening and assessment process are to determine the patient's clinical eligibility for buprenorphine treatment. So that's why the clinical coordinator evaluates the inclusion and the exclusion criteria. The clinical coordinator is responsible of document patient's health history, including medical, mental health, substance use, and previous treatment as well. Make any referral, for example, participant who has comorbid medical condition or psychiatric disorders, unattended or unstable. The coordinator also prepare the patient for treatment. We have to complete a treatment agreement describing the goals, the risk, and the benefit of the treatment. We have to refer for any other service that the participant has or needs, and then we have to prepare the patient for the induction process. We have to prepare for the induction process. We have to explain the necessity that they have to show some symptoms that we call withdrawal symptoms before they begin the treatment. And then we coordinate the appointment for the induction process. And maybe Diane can explain or give more information about some challenge that we experienced during this process.
Yeah, absolutely. Thank you, Delia. So when patients are scheduled for induction, a lot of times, at least for our group, most of our patients are Medicaid eligible, and so had Medicaid managed care organizations. When we first started, these companies required prior authorizations every 3 to 6 months, and although I often did try to fill out the paperwork as quickly as possible, I sometimes got these were delayed, or we wouldn't get the patient would lose their insurance suddenly, they would lose eligibility, or they wouldn't recertify, and all of that would delay our induction. And then, so we tried as much as possible to not induct a patient unless we knew that they were going to be able to continue on the medicine without any other financial issues. The group in Centro also said sometimes, you know, in order to start patients on Suboxone or buprenorphine, they have to arrive in withdrawal. But as anybody who is working with people with substance use disorders, particularly with opiate use disorders, these patients tend to have low distress tolerance. And so the idea of coming into clinic in withdrawal is really difficult. And so particularly for the patients who are driving from several hours away. So like we've mentioned earlier, my patient population comes from half the state. And so a lot of them would have 2 hour rides to get to the clinic. And driving for an hour or 2 hours while you're in withdrawal is not fun. And then we also had other transportation issues that would arise between, that initial appointment or induction, and just trying to get them onto the medicine sometimes took several visits. So I think Jason's going to take over once we got the patient in on the medicine to see what happens.
Yeah, so our test patient, if he or she were continuing on a linear path, would complete the induction and is ready for maintenance. Our monitoring appointments would consist of reviewing the last talk screen, discussions around cravings, how the patient is developing and using his or her sober support system, and then finally providing them with a refill of the buprenorphine. But ultimately, as this is an HIV intervention, how is this affecting the patient's adherence to medication, HIV medication? But as we know, life and addiction get in the way, and many things can lead patients and the monitoring visit off this linear path. So as far as the things clinical coordinators have seen that disrupts the monitoring visits could be things like the last urine screen that we're reviewing may show continued use of opiates and or other drugs. So we're asking the patient, maybe you were trying out other drugs to see if you could replace the opiate use, or maybe we found some patients actually have a co-occurring addiction to another substance such as cocaine or methamphetamines. So the discussions with the patient around strengthening sober support systems at this time can help, talking about people, places, and things, dealing with cravings. And then I also have found that reviewing the patient's goal of being on MAT, which is a question that we ask in the beginning, what is your goal here? And they usually identify it as abstaining from opiate use. Just reminding them that that's the goal here, and hopefully this kind of motivational interviewing can help get the patient back on this linear track. Another interesting occurrence that clinical coordinators have seen is around providing the urine sample. So patients we've seen may try to falsify urine samples by providing us with samples that are obviously not theirs. We've gotten cold urine, hot urine, urine in a condom. We've seen lots of different kind of tricks. And this led us to, at Metro, to place a temperature gauge on the urine cup so that we can make sure that the urine sample is valid and the patient's it is the patient's sample. If we found that the temperature is too high or too cold, then we'll have the patient provide us with another sample before they're able to get their refill. And then something else is that we look at here is behavioral health needs. Maybe now that their use is stopped or has decreased, maybe now we can focus on some behavioral health needs and get them into treatment. Maybe if they're relapsing or continuing to use, maybe there's some, I don't know, some manic episodes that are causing multiple relapses. So this could be a good time to address that. And then another snag that we can see in monitoring visits is that the urine screen does not show any buprenorphine in the patient's system. So here we're having discussions around when did you last take the buprenorphine? Did you take it more frequently than prescribed and then you ran out too soon? Or maybe the story of the patient isn't quite making sense and you develop concerns that the patient is diverting the medication. So here the clinical coordinator may think about more frequent monitoring visits, like maybe weekly, twice a week, or even perhaps even daily dosing that we've done, I think Diana talked about. And the goal here is not to punish the patient, although I've noticed that oftentimes the patient feels like it's a punishment, but it's more of a way to get a handle on the patient's motivation to effectively use the MAT to treat his or her opiate addiction. And then finally, if a patient's missing monitor appointments altogether and they come back a few days later, you're wondering, how did they get through those couple of days? What barriers maybe came up that they missed the appointments? So then we might revisit transportation, or maybe appointment time isn't the best for the patient, so we try and be flexible around that so that the patient doesn't run out of the buprenorphine and have to revert back to opiate use. So these are some examples that we have seen during monitor appointments. Patients with the goal of truly abstaining or reducing opiate use will work with you through these bumps in the road. But Kristen, these bumps will make the clinician wondering if the patient needs a higher level of care.
Right. Thank you, Jason. So I'll briefly touch on kind of what looks like, you know, a different system of care for your patient. One thing really quick just to reflect back on, as my colleagues have already mentioned and highlighted here, is that really this pathway, this nonlinear pathway that you see, is really the norm for the patients that we work with. And as my colleagues have demonstrated, just being flexible and being willing to meet the clients right where they're at. You know, if they come back and are managing, you're having discussions around urine screens and things like that, that there's always just this welcome attitude to have clients come back into care wherever you can meet them at and get them into care. And just a reminder that each patient's journey along this pathway is unique, and there's no one-size-fits-all for treatment. So that being said, we've had clients, definitely during the time that I've been doing this work, where we've realized that they may need another form of treatment. Diana mentioned earlier the difficulty it can be for a client to show up into the office-based setting while in withdrawal. And so sometimes we've had clients who just have really struggled with that, and we've had the ability to refer them to our local detox setting. They can get started on bup there, and then they actually transfer back to our care, and then we continue to do their dosing for them in the office-based setting once they've gone through the induction in a detox setting. Other clients, I've had one client who we tried so many times to get her in and start bup, and then one day she just called up and said, you know what, Kristen, I really think I just need to be on methadone. And so we help facilitate that handoff over to a methadone clinic. And then just to keep in mind, there's all the, other different treatment modalities. A lot of our clients coming out of jail have been offered Vivitrol or naltrexone, and so that's something that that we continue to offer to patients if that seems like a good fit for them. So I think just kind of the takeaway here is just to remember to be really flexible and willing to meet the client where they're at. And then just one last thing to say really quick on this is that one thing we realize is that sometimes, even though the client may be all over the place on this pathway, sometimes we're the only place that they can show up for, and that we are the highest level of care in which our patients can get to. So just having that radical flexibility to kind of meet them where they're at and continue to provide this service is really important. I think I'm going to hand this back to Alexis.
Sure. So thank you so much, clinical coordinator teams. I was thinking about all of the amazing things that you do along this treatment pathway, and I really do feel like they're amazing steps. So the volume of knowledge that you hold in your head about the individual experience of each client, and not only each client, but about their home and their family lives and the barriers that they have to staying on their buprenorphine treatment or diverting their meds. If they have somebody at home who is also trying to work on their substance use disorder who doesn't have the same access to care. You do everything from screening clients to make sure that they're a good fit for the buprenorphine program and that buprenorphine is actually a good fit for them, to communicating with primary prescribers, to talking to treatment team members who may not be as familiar with substance use disorder or may have a more rigid approach and not want to be so, as Kristen says, so radically flexible and welcoming people back at every time that they want to come back into the clinic. Another thing that we didn't really talk about in this graphic but I think is really important is that clinical coordinators track people down. They go out into the community or they go around the hospital setting or to community partners to say, hey, have you seen this patient? I'm looking for them. I'm trying to keep them engaged in care. So they don't just sit in the hospital waiting for somebody to come to them. They're out in the community trying to find their clients as well to make sure that they have continuity of care. So we just have some quick lessons learned across the buprenorphine intervention that we wanted to share to highlight some places where the clinical coordinator takes a larger role and some of the phases of the intervention as well. So Jason, I'll hand it off to you to talk about internal buy-in and engagement, which is really like the first piece of getting any of these programs started.
Yeah, it was the first piece, and it's such a key piece to building a foundation for this intervention. Although the doctors and the clinical coordinators are the main players, patients still need to be checked in by the front desk staff, and their vitals are taken, and they're roomed by the medical assistants and the nurses. So everyone is ultimately involved with the patients, and you want to have buy-in from everybody. And as we talked about the induction phase, we're asking patients to come in withdrawal, so they're not feeling their best and may not be on their best behavior. So getting staff to see why this is happening is important so that they're still willing to work with the patient, have a relationship with them, and help them out. What we did, just to quickly go over what I thought worked well with at our clinic, was instead of simply telling clinic staff and administration what we're doing, we wanted to also tell them why we're doing it, and we wanted to build that case. And we had a training of all of our staff, and administrators were involved in this training at the beginning of the information, and we showed people the statistics around how the epidemic was hitting Northeast Ohio at the time. We had an amazing training on the disease of addiction, so that staff that maybe hadn't gone through that training could better understand addiction and the addicted brain. And felt that those two things combined really, that and we did at the time, we had lost a couple of patients to overdose deaths, and those things combined, we were really able to make everyone see and feel like they wanted to be involved in part of this solution that could save our patients' lives. And then also, I want to emphasize how important it is to have these discussions around the harm reduction versus abstinence-based treatment as far as your buy-in and when you're sitting down with staff and discussing all of this, because this is a complex issue. issue, and there are varying views on different treatment options. If they are using less drug opiates but are still using, are we doing them any good by continuing them on MAT? Or is this is, as Kristen said, they come to us. We are the highest level of care that some patients may know, and that is good for some staff members, and then other staff members may have a problem with that. So just having open discussions about that, I think, is really important in those early stages.
Great, thanks, Jason. So something that I heard you saying is you need to be armed with both statistics from your community around overdose deaths and the epidemic, and you are armed with also personal stories of maybe patients that multiple clinic team members knew who had overdosed. And then you did trainings on addiction medicine and your clinic philosophy to create a common language. So everyone, even if they weren't necessarily interacting with a patient on a given day, they were all on the same team trying to reinforce a message around low barrier MAT.
Yeah, that's what we did, and I thought it worked out pretty well.
Great, thanks. So Anna and Delgia, I'll pass it to you to look outside of your community for allies and partners.
Yes, looking for allies and partners is very important. This is a process that you have to realize and from the beginning of the implementation of this project. The objective is identify the lack of certain services offered by your agency, anticipate participants' needs, and establish relationship for referrals, to receive and to make referrals. As Center of Ararat, we develop different types of relationships with community agencies. We have contracts. That means that Centro Ararat pay for some services that our participants need, like housing. And we have collaborative agreements or memorandum of agreements. And we also have a referral link to make referrals as mental health, detox, residential, and outpatient treatment centers. This is a process that doesn't have to end. So if you want to make your project or work with the sustainability of this project, you have to develop, you have to build, and strengthening the community collaborations.
Great, thank you. I think something that we heard loud and clear when we came to do site visits with you all and when we talked throughout the 3-year initiative is that you can't just do this alone, right? It can't just be one prescribing provider working by themselves, but it really takes a whole community to support a client. All right, so Diana, can you talk to us a little bit about provider and clinical coordinator capacity?
Oh, absolutely. So as we discussed earlier, our patients don't always have this linear path. And so when we initially started this program, we were like, all right, we're going to get people in, and we had this waiting list of like 15 people who we were going to get in, and it became very clear within the first month or so that although the guidelines for our state prescribing for buprenorphine was you get them in, you see them once a week for a month, and then you can go to 2 weeks, and then you can go to once a month. The reality was that our patients were needing to be seen at least once a week, sometimes more. And so the more we saw each individual patient, the less we could kind of take on new patient-wise. And I think that is, I know we had a question about the difference between a navigator, a patient navigator, and a clinical coordinator. And part of that, I think, comes into a patient navigator really works to link somebody to care, whereas the clinical coordinator, like I was in the front lines throughout the whole treatment process. So I was meeting with the patient in clinic with the provider, but I would also meet with them and do, brief counseling and addiction skills building and supervised dosing for those patients who needed more care. So it wasn't just like a warm handoff or a, here's how you navigate the healthcare system. It's more engaged in actually treating the patient's needs. Yes.
Great, Diana. Yeah, thank you. And then Kristen, I think, had a little bit more about the patient navigation versus clinical coordinator role, and was also going to tell us a little bit about the landscape of MAT, which is constantly changing.
Yeah, thanks, Alexis. So first of all, I just want to say, we started this back in 2005, so it's been 14 years since we've been doing this. And although I'm listed as a technical assistance provider on this evidence-informed intervention, I really learned from my colleagues here. I think I found when we're looking at the landscape of MAT and how it's changing, I was really excited to just watch each of these teams create these amazing programs, and they just naturally incorporated some of the key things I think that we're going to continue to see on the landscape of MAT and moving forward. So, for example, Diana's team, I think she mentioned earlier and talked about insurance access in the beginning and how hard that was, because you have these people that are ready to treat, but you have to do a PA. And I just loved how that team, incorporated radical harm reduction and as rapid of access as possible while waiting for insurance to come online. I think Jason's team, when we were working with them, the Ohio team, they really incorporated culturally sensitive services to the populations services for the direct population that they served, and I was really impressed by that. And then Ana and Delhia, their team over in Puerto Rico, really highlighted the importance of that kind of street-based outreach that they do every day that helps keep people connected and linked to services. So just a quick shout out to my colleagues, because it was really exciting to see them take this and just do such an amazing job. I think I'll just go really quickly and then leave it open to people on the call to also comment in if they want to. But basically, I think when we look at MAT and where this is going to go, we're hoping to see some more streamlined, trauma-informed intake processes. So we know that the sooner we get people into care, the better. Get the medication in their hand, and then from there work on connecting them to services. So again, once they're in care, provide more low barrier services, same-day inductions. We're looking at home induction protocols here in our clinic because we're realizing that's going to be important. I've heard about really cool outreach programs that are using mobile vans, and they're getting the services out to the people who need it the most and who often can't even show up into the clinic setting. So we're excited to hopefully see that happen. I think more collaboration, and my colleagues have mentioned earlier how important it is to get community partners involved in the work that we're doing. And so just seeing more collaboration across community partners, such as working with the jail systems. We work in a 3-county area, and just in June, the 3rd county finally added MAT, the 3rd county jail just added MAT to their system. So it was really exciting to see that happen. But also working with community partners in housing, treatment programs, EDs, and hospitals to help, get people connected and on care. I think during early recovery, we really want to focus on resources primarily. We work with a disenfranchised population. A lot of the clients we work with in our setting are homeless. And so we realize the first thing they need is shelter, wound care, showers, food, transportation. And those are kind of what we did in the beginning. And then the other services such as the interventions, the counseling, and relapse prevention came a little bit later after they were stabilized. Yeah, and I think a couple other things. Polysubstance use is going to be the norm, as my colleagues have mentioned, but that we just kind of continue to provide that consistent and reliable treatment program while also working with that polysubstance use. And I think Diana mentioned in slides earlier, this is really chronic disease management, so bringing it into the clinic setting is ideal, and this is the best place to do this kind of work.
Great, thanks, Kristen. And I'll pass it to Diana for our lessons relearned.
Yeah, and we're running low on time, so I just wanted to it was important for us to remind to be reminded that this is a chronic relapsing brain disease. The path towards stability can be a little wonky at times. People can stabilize and not stabilize, but also that medicine alone, in my opinion at least, is not always the end-all be-all, because it doesn't treat other substance use disorders. And so using every possible opportunity we can to just reach out to our clients and meet them where they are, and then support each other, because it can be hard to work with clients who are, doing great 1 minute and then falling apart and then doing great another minute. So those are just really important lessons to just remind ourselves about.
Great, thank you. So we wanted to point everybody to some resources and some next steps that we have. So one of the things that I was thinking about when Kristen was talking about the landscape of MIT currently changing, and Diane was talking about lessons relearned, is that part of what our job is at APT, BU, and AG United is to produce what we're calling care and treatment interventions, affectionately referred to as the KDs. And they will be available in 2020. So these are new and improved implementation manuals that take the framework of the interventions that you had heard about earlier, all 4 of the interventions, and then specifically this intervention, and incorporating our lessons learned, our findings from our multi-site evaluation, qualitative and quantitative data, so that you can have a really robust manual to refer back to. So if you're interested in learning more about the KDs, I'll share my contact information at the end, and we can put you on the distribution list for that. Another thing that we'd like to draw your attention to is the Target HIV site, and this site has all of our materials. So it has the current intervention manual, it has site spotlight. So the 2 that you can see below, one is about working as a treatment team, and one is about the work that Centro Ararat did in the wake of the hurricane to keep all of their clients engaged in care. So in the wake of the hurricane, the Centro team was able to maintain all of their buprenorphine clients in care. They did not lose a single patient in that natural disaster. So you can check out more information there. And then we just have just a few moments, and we have some questions rolling in. So I'll just answer one of the questions that we have coming in, and then I'll share my contact information so that if folks have additional questions, and we hope that you will, you can let me know, and we can produce an FAQ document as a result of this webinar, so we can share any questions that came up from our attendees or any things that the panelists wanted to add to their content. So one of the questions that came in was about how the clinical coordinators are funded, and how states are committed to MAT, but providers are having challenges maximizing waiver capacity and really want to integrate clinical coordinators but aren't sure how to pay for them. So some of the answers that are rolling in from our panelists are that they are leveraging Ryan White funding. They're talking to their county board of addiction, and some of the Medicaid covers intensive case management and counseling, and they might be able to, people might be able to look into paying for the position through insurance payments. So that's kind of a brief overview of ways to pay for this, but I wanted to reiterate that the folks who have participated in this webinar, so all of you who are listening in from around the country, you are now part of our clinical coordinator community. So if you have questions, if you need resources, if you get stuck, if you have, if you're looking to start up a program or your program is struggling in some way, please reach out to us. We are here to help support you and share any of the lessons learned that we have. So some of the other questions that are coming in that we'll be able to answer in our FAQ documents are about the success rate for MAT, rate of relapse. We'll have some information from that from our multi-site evaluation, and we can point to some national statistics as well. And we want to let everybody know that this PowerPoint, a link to this recording, will be emailed to everyone who participated and folks who missed the webinar as well. So You can take a look at the slides, you can listen to the recording, and then let me just share my contact information. So please feel free to email and let me know any questions that you have for the folks either at Boston University, APT, AIDS United, or any of our clinical coordinating staff or teams. So just looking at the time, we're at 1:59. I know everyone has really packed schedules and are trying to get back to their clinical work and all of the responsibilities that they have. So we just really appreciate your time, and I'd like to thank all of the clinical coordinators, our HRSA project officer, Dr. Corliss Heath, and the app team who supported this webinar for making this happen. So thank you all for participating, and we hope to hear from you soon.
Thank you.
Thanks, everyone.
Bye, all.
Thank you.
Have a good afternoon.
Bye. Bye. Thank you.